I would request to call Bansri Mahadevia, MBBS MD dermatologist, founder of Be the Changes in Skin Clinic.
Very good evening, everybody, and thank you so much for having me to the PCOS Society. Thank you so much for having me today. My topic for today is that why do we look for, how do we look for acanthosis nigricans, and why does it occur? Now, it's a very broad term to give. Why does acanthosis nigricans occur, right? So, why it occurs actually depends on why it is happening. Right, so each etiology will then correlate to why it is actually happening. So before I begin, why is a dermatologist even present over here, right? So there's a lot of correlation between gynecologists and dermatologists. Almost 70 to 80% of women with PCOS present with dermat symptoms, and there are a lot of skin manifestations often precede systemic symptoms. So that's a very, very important thing, that as a doctor, our main responsibility is actually prevention rather than curing, and that's why skin manifestations actually appear first before the actual internal manifestations begin. So that's how a collaborative approach will eventually help our patients. So like I mentioned, why does it occur? To understand the why, we need to know the types. So my aim for today is anyone who's listening to this lecture can go home thinking that acanthosis nigricans has a cause other than insulin resistance. So we all know that AN is associated with insulin resistance, associated with diabetes, but what else? When do we reassure your patient that, okay, you don't have an issue? So many times we need to know why do we have an issue, but we also need to understand very deeply when does the patient not have anything, right? So coming to 5 very simple, short and sweet cases, that supposing there's a 49-year-old woman, there are many, many cases like this which come in our daily clinical practice. Obese, increased BMI, but the blood sugar of this lady is normal, right? If you do her fasting insulin, it is normal, right? So now we might think, why does she have so much, darkening in the underarms, darkening in the neck, but all her parameters are normal. So I would really like to specify over here that obesity-associated acanthosis nigricans, also known as pseudo-acanthosis nigricans, is the most common cause of AN, right? That is acanthosis nigricans. And we don't need to do anything for this patient. We just need to ask her to lose weight, right? And this usually happens when more than half of the adults who weigh more than 200% of the ideal body weight develop this AN, and trust me, all the other parameters would be normal. So this is the most common cause of acanthosis nigricans, and not just insulin resistance or diabetes mellitus, right? So the lesions are weight dependent, and with regression of the weight, the lesions also will improve. Then the second case is this, where the patient is also having hirsutism along with acanthosis nigricans, and a lot of symptoms of hyperandrogenism. So a lot of you in the audience might be able to tell this syndrome, that is the Hyran syndrome, where these 3 things are present together, right? So that is the coming to the second kind of acanthosis nigricans, which is the syndromic acanthosis nigricans. Now when we talk about syndromes, again it is of 2 types, type A and type B. When we talk about type A, it is the Hyran syndrome, which has all 3 kinds of hyperandrogenism, insulin resistance, and your acanthosis nigricans. So all 3 together. When it is present together, that is when it is your Hyran syndrome, and then she most likely, these kind of patients would also be having PCOD, PCOS, diabetes mellitus, and insulin resistance. Then comes the type 2 syndrome of acanthosis nigricans, where there is some kind of ovarian hyperandrogenism, there is some kind of autoimmune condition, there is some kind of systemic disease other than diabetes also, which can cause to the hyperpigmentation in the underarms, the neck, and the knuckles. So basically, supposing if you see a patient having darkening and typical AN features, this is how we would usually proceed. We would try to rule out for PCOS and insulin resistance, and if not, that doesn't mean it's the end of it. There can also be certain systemic conditions which are associated with AN. Okay, so just a very quick thing, being a dermatologist, the skin is always going to come up in my slides. So if we can just understand the anatomy of the epidermis to understand why AN actually occurs, at the biochemical level. So if you see, the skin basically has two layers. The topmost layer, which looks like a wall of bricks, and then is the lower layer, which is the dermis. So it's the epidermis, which is outside, and it's the dermis, which is inside, right? And between your epidermis and dermis is the epidermal-dermal junction, right? Now what happens? And if we just understand this one slide, I think we'll understand why AN actually happens, right? So what happens is that when the serum insulin increases a lot, which we often call as hyperinsulinemia, the insulin actually migrates in between the dermo-epidermal junction and goes towards the epidermis of the skin, right? So from the deeper level of the tissues, it migrates and goes towards the superficial skin, which is the epidermis. And within the epidermis, the skin cells, which we call as the keratinocytes, which actually harbor our melanin, they are present and they get stimulated. So when they get stimulated by the excess insulin in the body, they are going to proliferate and they are going to thicken the skin, right? So that is why it happens. So now, like I mentioned again, depending on the reason that why acanthosis nigricans is happening, the pathophysiology or the why of the acanthosis nigricans will vary. So when we talk about patients with PCOS or with insulin resistance, the main cause is this, that when the serum insulin level is increasing in the body, it will actually replace the insulin binding globulin to the receptor. So instead of the IGF binding to the insulin receptor, the free insulin itself starts binding on the receptor and causes the proliferation of the keratinocytes. Secondly, what happens in case a patient is having some kind of malignancy? In malignancy, there is the level of TGF beta, which is rising in the body, and that causes a proliferation of the epidermal growth factors. So epidermal growth factors again migrates to the skin and causes proliferation and thickening of the skin and the epidermis. So that brings us to two of the main pathophysiologies which are involved in why the acanthosis nigricans occurs. The main thing is, like I mentioned, the insulin level increases, it crosses the DEJ, that is the dermoepidermal junction, to reach the keratinocytes. Of course, depending on, sometimes you will see some patients having excessive darkening of the underarms or excessive darkening of the neck, and some people might even have it mildly, right? So that is a very mild form, and it's very good to catch it early because, it is kind of just begun, right? And the second reason also is that when insulin level increases in the body, the free insulin binding globulin also reduces. So the proteins which are actually bound to insulin in the body, they also reduce. So, that kind of is a positive continuous feedback mechanism where the free insulin constantly keeps increasing and causes the proliferation of the epidermal dermal junction and the keratinocytes. Again, this is the same thing that I just mentioned. Now comes the third case. The first case we talked about was somebody just being a little overweight and having very plain sugar parameters, nothing, no increased free insulin. That is the obesity or the pseudo acanthosis nigricans. The second is what we talked about, the metabolic syndrome, PCOS associated acanthosis nigricans. And the third is something like this, where you will see that, okay, she is having a buffalo hump, probably not so severe, but something like this, where, having hair fall, acne, a lot of stretch marks. So this time, the main question should be, what medication have you been taking, right? And most commonly, it is either the oral contraceptive pills, which can also lead to acanthosis nigricans, and it is not the altered sugar levels, and also the corticosteroids or the excess use of corticosteroids. Another thing is insulin injections. Type 1 diabetic patients taking insulin injections can also have acanthosis. So that brings us to the medication associated acanthosis nigricans, and this is the pathophysiology behind it. Whenever there is the glucocorticoid excess, it directly acts on the insulin receptors to cause AN. Fourth case is, many times we see that there is knuckle hypopigmentation, and many times we think that, okay, this patient is going to have some B12 deficiency. But it is very commonly known that, knuckle pigmentation is associated with B12 deficiency. But if you see the B12, it is fine. the sugar levels are fine, and there is absolutely no insulin deficiency. So what is it? It is a very simple acral acanthosis nigricans, meaning it is nothing is to be done in the patient, no medication, and it occurs just in dark-skinned individuals without just being idiopathic. The next case is a middle-aged female patient, with a malar rash and a positive ANA titer. So probably these patients might not come directly to a gynecologist, but just mentioning because any kind of autoimmune disease can also have acanthosis nigricans as a presenting feature in the earlier symptoms. So it is very important not to miss doing the ANA titer when you see the patient having hyperpigmentation, and also systemic symptoms like rash, photosensitivity, joint pain, fever, difficulty in swallowing, and the other symptoms as well. So what happens in autoimmune condition is the antibodies, just like how glucocorticoids were attacking the insulin receptors, how the free insulin itself displaces the insulin-like growth factors and itself attacks the insulin receptors. Antibodies, because of these people having a excess reaction of the immune system, they can also attack the insulin-like growth factor receptors, which can eventually cause hyperpigmentation and acanthosis nigricans. So that eventually brings us to the last three types of acanthosis, which is the unilateral acanthosis. This also again might not come directly in contact with gynecologists, but it's just important to rule out so that we know how to manage this patient further, right? Which is a very unilateral or a nevoid, which means that this kind of an AN will occur only in one part, and it will occur along the Blaschkoid lines, right? Our Blaschkoid lines, it will occur along that. And then comes to the familial acanthosis nigricans. Again, this is something which just runs in the family. It's just hereditary. It does not have to have any kind of abnormal parameters, to show the acanthosis nigricans. And finally is the benign genetic acanthosis nigricans. So this is something which can be present since childhood, and it can even be present during birth of a baby. And there is no other kind of endocrinopathy that is important. So why I wanted to mention these types of acanthosis, because the management of the patient will vary depending on the type, and the how and why the acanthosis is occurring will depend on the kind of the acanthosis nigricans that is actually present in the patient. And why I'm mentioning, because as dermatologists we have seen that there are so many patients who are really fed up and very upset even mentally that they are not getting results, with the reducing in the darkening. And that is because it is not being diagnosed that why it is actually happening. And most of the times we just keep thinking probably it's just some kind of insulin resistance, that is causing it. So the question is not how do we look for acanthosis, because that is very easy. It's very easy to see the pigmentation on the flexural areas. The question is that how do we ask for acanthosis nigricans? So looking for it is very easy. The neck, axilla, groin, knuckles, the flexural aspects. One thing which is often missed is the facial acanthosis nigricans. So many times we feel that this is just some kind of an excessive tanning, or it's aging, or it's photodermatitis, but acanthosis nigricans can actually present even only on the face. And that patient might, might need to do the sugar profile of patients like these as well. And that's why, if not diagnosed correctly, we can actually change the management of this patient completely. So like I mentioned, it's not about, just seeing that where is the acanthosis nigricans. It's about what questions do we ask. And I'm just going to summarize the entire thing, that when it is obesity-related acanthosis nigricans, did we check for her BMI and ask for weight gain? When it is some medication-associated AN, did we ask for a medication history? Did we ask for history of stress? History of stress is extremely, extremely important, because we don't realize in today's time and age, because of stress, there is a chronic increase of cortisol in our body as well. And that cortisol is a killer, right? And it's not ki chalo kale exam che as a stress thayo and cortisol vadyu. That's a good stress to have because it's extremely temporary. But it's when that cortisol is raised in your body for a very, very long time that it can actually cause, hair fall, acne, acanthosis nigricans, weight gain, acidity, and whatnot, right? So it actually is proven to increase your blood cortisol levels. So did we ask for stress? Did we ask for oral contraception history? Did we ask for the BMI and the weight gain? For the syndromic acanthosis nigricans, did we check for other symptoms like photosensitivity, joint pain, family history, the ANA titer, the HOMA-IR index? We often forget that, just last two things. And yes, for B12 deficiency history, the trait along the Blaschkoid lines and the family history is extremely important. So right, the diagnostic approach is very common, just for PCOD and onset. And the last two lines that I will say is the role of adipokines. This is something which is very, very new for acanthosis nigricans, and it is showing a very new role in metabolic syndrome. It is produced from fat cells, and this test is now not available in India, but available only in the US, where it is a big marker of early detection of insulin resistance and the gut microbiome association with insulin resistance. So thank you so much, and just these are the key takeaways, that it is a cutaneous marker of a systemic issue. Proper classification is extremely important to understand the etiology, and there are recent researches which focus on molecular therapies and microbiome therapies, and a multidisciplinary approach is extremely important. So thank you so much once again, and I hope it was helpful.
Thank you, Dr. Bansri.